So just to start off the second session, I'm really pleased to bring Dr. Bridget Johnson into the area. She's a palliative care physician at HammondCare and Royal North Shore Hospital, and Bridget's going to talk to us today about the role of community palliative care teams in tumour relapse. Thank you, Bridget.
Good morning, everyone, and thanks very much for having me here to speak. My name's Bridget Johnson. I'm one of the palliative care specialists who works here at Royal North Shore Hospital. And I'd just also like to introduce Anne-Marie Perry, who I've got up here at the front, who's one of my delightful colleagues who works as the nursing manager for HammondCare, which provides community palliative care here in Northern Sydney. And she's going to be here when we have our Q&A session later on in case you've got any specific questions about palliative care. So I've been asked to talk today about the role of palliative care teams in tumour relapse. And I appreciate for a lot of people you probably looked at the program and thought, that's not really a session that I'd like to attend, because that's often the feeling when people hear the word palliative care. So if that's the case for you, I just want you to take a little bit of a step back and think about the session today actually through the prism of if we were talking about someone else in your life, a friend, a family member, maybe someone who's getting a bit older, someone who's getting a bit frailer, someone who maybe has a life-limiting illness. And just think about whether palliative care might be something that actually could value add for them or could be helpful for them. So with that in mind, what we're going to cover today is just some discussions about what is palliative care, what does that mean, what does that potentially contribute to someone's care? What does community palliative care look like? Who's in the team and how does that work? And then a bit of a discussion about advanced care planning, because regardless of who you are, actually everyone should be having these discussions. Every adult in Australia should be having some discussions with their families just about your values, things that are important to you and how you'd like to be treated, because that can make sure that it puts you in the driver's seat in terms of your healthcare journey, wherever that might go. So, to start off with, in 2019, Palliative Care Australia did a survey of 1,000 Australians, asking them their opinions about palliative care and things that were important to them. 82% of Australians said that they would ask for palliative care for someone close to them if they had a serious, prolonged, or terminal illness. In the same survey of 1,000 Australians, 79% of Australians said they think it's important to think and talk about their preference for care at the end of life. But there's a disconnect between what people think and actually then what happens in practice. Because actually only 25% of them had talked to their family about these issues and only 6% had spoken to a doctor. So how do we go from the 6% to the 79%? Let's talk about palliative care. I appreciate that for a lot of people, they think talking about palliative care is morbid, it's taboo, it's weird, but the truth of it is it's actually a part of life. The best way to deal with fear is to confront it. So let's lean into this a little bit and just talk about palliative care. So the World Health Organization defined palliative care as an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illnesses through the prevention and relief of suffering by means of early identification and impeccable assessments and treatments of pain and other problems, physical, psychosocial, and spiritual. This is from the Cancer Council Association's website. It's just got a nice summary of what palliative care is, and there's actually some really good online resources that just in a really practical way talk a bit about palliative care. So in this, I think it just sort of outlines really what we're going to talk about today in this talk. Palliative care is patient-centered care, and it's care that can be provided either in someone's home, in a hospital, in a palliative care unit, in a nursing home. We'll discuss when you should start and when you should think about when it might be appropriate to be referred to the community palliative care team, and talk about who might be in that team and the care that they provide. And then in addition to that, we're just going to talk about what potentially palliative care services can help you with in terms of support and helping with advanced care planning. So the public healthcare system, as I'm sure all of you already know, is a huge machine, and it's a very confusing machine. So when you look at a map of New South Wales, this is divided into local health districts. So all of this money comes from the federal government. It then gets given to the local health services. And it's the local health services that then decide the palliative care services and how they're allocated and how the federal money, Medicare money is then allocated. So you may then have a confusing situation. If you live in the middle of a local health district, you'll probably know who your local hospital is and who's providing your community service. But if you live at the edge of a local health district, you might have people on one side of the road who would get their palliative care in the community provided by Western Sydney Local Health District, and people on the other side of the road have it provided by Northern Sydney Local Health District, which obviously is extremely confusing. The other thing to know is that palliative care services are predominantly publicly funded and funded by Medicare. But Medicare sometimes outsources that to non-government associations. So you'll hear terms like HammondCare, SilverChain, Calvary. These are all not-for-profit, non-government organisations, but the money comes from Medicare. So it's actually a publicly run service, but different area health services allocate that funding differently in terms of their providers. So how do you know where you fit into this? Well, actually, there's a really nice reference point on the Palliative Care Australia website. You put in your postcode there, and I just put in North Shore as a postcode because that's where we are today. But they give you a long list that continues down the page of the community services, the clinics that are around, and how you can get in contact with someone. And that helps at least to break it down a bit in terms of an otherwise very confusing system. So the question often comes up, well, who is in the community palliative care team? So generally, and this will be regardless of what area health service you live in, the community palliative care team will be made up of palliative care nurses, and most of these services are nursing-led services. We have amazing subspecialist palliative care nurses, and frankly, they are the backbone of how palliative care is provided. There will often be in these teams a palliative care consultant and a palliative care registrar, which is someone who's training to be a consultant. There'll be social workers who can then assist with psychosocial support and helping to sort of navigate some of the sort of systems and things you might be eligible for. Physiotherapists who can help with mobility and if mobility is changing. Occupational therapists who again can help with functional changes and equipment within the home. Pastoral care workers who can help with psychosocial support and spiritual support. And often these teams will have volunteers as well who can help in the picture as well. So what help can I get from the community palliative care team? Well, you can get advice about symptom management. And often, particularly if you've got a longer term relationship with the community palliative care team, they can give advice about potential symptoms that might come up in the future and be proactive about trying to manage those symptoms. They can help provide psychosocial support for you and your family, because we appreciate that this is a really challenging and confronting time for patients and their family members, and assistance with facilitating equipment at home to assist with mobility. They can also provide assistance with navigating advanced care planning. So how much will palliative care in the community cost? So the community services, so that team that I spoke about with nurses, doctors, allied health, is all publicly funded. So taxes have already paid for that. There's no out-of-pocket expense for that. But it's where that dovetails with other systems that things actually can incur a cost. So often with palliative care, we work really closely with general practitioners, but GPs will continue to charge someone either bulk billing or private billing, depending on what they usually do. And so there might be a cost for home visits from a GP. Medications are not covered by the palliative care team, so again, they will continue to incur a cost that will be subsidised by the PBS. If the occupational therapist advises equipment in the house, often that will be hired, so that may have a cost that comes along with it as well. And if you need extra nursing care at home, a lot of these services don't provide the physical nursing care at home. So if a decision is made by a family that they're needing more nursing care, often that will be through a private agency, which can be costly. So how can I be referred to the community palliative care team? So usually a referral takes place either from your general practitioner, the specialist who's looking after you, or one of the nurse practitioners or nurses who is involved in your journey. And at any stage, if you've got questions, you can ask, actually, can I be referred to the community palliative care team? Sometimes people will be referred, will see the team once or twice, and then be discharged because they don't have care needs now. But for some people, that helps to build a relationship and start to know who that might be and what that might look like if they're having increased care needs. So the question is, when do you access community palliative care? So generally we say anyone who's got a life-limiting diagnosis, so an illness that is going to get worse and which will eventually shorten your life. Plus, in combination with that, symptoms that you need help with managing, or if you're having increasing care needs at home, because they're things that the community palliative care team can then assist with. There's a few myths about palliative care, and there's many myths, but these two in particular I wanted to point out today and try and dispel. I think for a lot of people, they believe that it's a one or the other. You're either having active treatment or you're having palliative care. And as someone who works here at Royal North Shore Hospital, that is just not the case. I would say, the vast majority of the patients that I see here are still undergoing some form of active treatment, be that chemotherapy, radiation therapy, or still having antibiotics and blood transfusions. The patients that I see have got a lot of symptoms, and so I see them to see what we can do to try and improve their quality of life and improve their symptom management. And a lot of people will get to a point in their journey where they say, I don't want to continue the life-prolonging treatments. But it doesn't mean that you have to be at that point before you get introduced and can have some benefit from palliative care. The other myth is that palliative care is just for the last days of your life, and it's not. I actually think the times that we can actually value add the most to someone is when we can actually genuinely make a difference to symptoms so that someone then has a better quality of life, and often hand in hand, actually having a better quality of life gives you a longer length of life. So I just want to shift gears slightly here and talk about advanced care planning, because I think it's really important and it's something that we don't speak enough about as a community. So I work here at Royal North Shore Hospital. I do see patients who have cancer, but actually I see a lot of patients who don't. I see a lot of patients that for them and their family member, this is one of the hardest days of their life because they've had a car accident, they've had a brain hemorrhage, they've been burned, something acute has happened. And all of a sudden, a lot of decisions need to be made either by them or by their family members on their behalf. And the patients and their families who've had these discussions around the dinner table months, years before it was relevant, it makes that hardest day a hell of a lot easier. So the question comes up, who do you want to make decisions for you? So 67% of Australians will have some kind of decision-making document in place. 43% will have a will, 18% will have a power of attorney, or that's someone who can make your legal and banking decisions for you if you lose capacity. 18% will have a nominated person to make healthcare decisions, and in New South Wales that's called an enduring guardian. And that again is someone who can make medical decisions for you, but only if you lose capacity. And 17% will have an advanced care plan or other documents outlining wishes for them at the end of life. I wrote my will and appointed a power of attorney and enduring guardian about 8 years ago. And I've got to say, I was surprised at how confronting it was to do that. Because essentially what you're doing is sitting down and saying to my husband, if I die, if I get hit by a bus on my way home from work tonight, this is what I want to happen with my money, with our kids, and with their future. That's a really confronting discussion to have. But often it's far better to have that discussion a long way before you need to, because actually that's the gift that I give to my husband. If God forbid something suddenly happens to me, he has a bit of certainty about actually what I would want to happen. So this is where advanced care planning also comes into place, and I've got some links at the end of this talk. But there's actually a really nice website that New South Wales Government has put up, which just talks you through how you can actually write an advanced care directive. Palliative care community teams can be helpful with this, but you don't actually need them for this. This is something that everyone could do either with their GP or just with their family members. And it just goes through and says, if you can't make decisions, who would you want to make decisions for you? It asks some things which you can see. You can tick unsure if you don't know the answer to some of those questions. But they're questions about actually what are the things that are important to you from a quality of life perspective. They then ask, do you have clear ideas? If it was the end of your life, what would you want? And again, you can say, I don't know, and that's perfectly okay. There are questions about medical interventions. Would you want CPR? Would you want dialysis? Would you want feeding tubes? And again, you can say, I don't know. And this can change. You can write this once, and then a month later, you might be in a different position in your life, and those decisions have changed. And that is perfectly okay. And then it just asks you if you've got some clear ideas about organ donation. And again, that's something that some people will have firm ideas on, and others may not. So just to end off the talk, I just want you to think about what is important to you. Because again, I think as a society, these are discussions we should be having. The Palliative Care Australia website again has some discussion cards which you can download or ask them to send out to you. And they're really just meant to be used as something to be discussed at a dinner party, around the table, to just think about what might be important to you. Being cared for in the place of my choice. Is that important to you? It may or may not be. Access to fresh air. Again, it may or may not be important to you. Talking about my fears and worries. Quality of life and what that might mean to you. Being independent for as long as possible. Being informed and involved in decisions about my care and treatment. Following my cultural, religious or spiritual practices. Not receiving intensive medical interventions. Receiving all available treatments, even if they make me feel sick. My pain and symptoms managed. My family and friends not having to look after me. Again, I think just being able to have these discussions is helpful for you and for your family members. Thank you.
Fantastic, really poignant. And I think it's great to have open discussions like that and just see what palliative care services can offer. And it's about, you know, as Bridget said, to do it early in the piece rather than think about it later.